Hi, everybody. This is Dr. Horn.
This is Dr. V. Good afternoon.
I hope you can hear me okay. Now, if you have any questions at all, please feel free to interrupt. Just feel free to stop us and ask any questions that you have. Right now, everybody is starting on mute, but you feel free to unmute yourself and ask any questions, and then we can go forward.
And then there's also the chat box. So if you want to send a question, you could just type that in there.
Yes, if you ask any questions by chat, we'll respond to those as well. So we're going to start today. This is part of our webinar series for our stewardship program. The use of procalcitonin and inflammatory markers is the subject today. So here are the goals. This is the goals for our talk today are to understand the origin of procalcitonin, identify when to order procalcitonin, how to interpret the results, review evidence supporting the use of procalcitonin in decreasing antimicrobial use in pneumonia and sepsis. These are the things we're going to be talking about today. This is one of the important parts of the talk is to realize that we need a marker for infections. Other kind of markers have come about in the past, and they've tried to support infections like ESR, CRP, but there really is a need for a marker. Antimicrobial use and misuse is the key driver of resistance. Up to 50% of inpatient antimicrobial use is inappropriate, and in nursing homes, that number actually goes up to about 75% of antimicrobial use is inappropriate or unneeded. Antimicrobials are not free from any consequences, and C. diff. Antimicrobial use is a big driver of C. diff infection. So using antimicrobials correctly is very important, and if we can have a marker that helps when patients have a bacterial infection, that would be really great. This slide is supposed to show the difficulty in diagnosing bacterial infections. I think we're all familiar with seeing patients in the ICU, and you get a chest x-ray and it comes back something like this, and not sure if there's an infection or not, and everyone feels more comfortable with antibiotics on board. They'll say, I just feel more comfortable, and may get an infectious disease consult, and we'll take a look at it, and we're not sure either. So we try to look at everything as a whole, but in general, it's very difficult to tell a bacterial infection from other causes.
So for example, this picture, when we see it, it could be fluid overload in a patient, it could be ARDS, it could be pneumonia. So what can help us kind of like say, okay, even if they have fluid overload, maybe they have infection on top. So is there, and procalcitonin kind of plays a key role in sometimes helping in these cases.
And not knowing if somebody has an infection or they're going into sepsis, but we do know that early antibiotics really have a big difference in outcomes. So this is a chart showing something that has been known for a while. This is kind of an old study from 2006, but it's something that everyone agrees on, and that's patients that are in sepsis, the faster they get antibiotics, the earlier the antibiotics, the better the outcomes. And so this is the odds ratio of death here on the left, and this is time.
Every hour, yeah.
That's time from hypotension.
So they say that every hour we are delay antibiotic therapy, your mortality is about goes up about like 7 to 10%. So it's really important, you know, even in the sepsis campaign, to start the antibiotic within the first hour.
And so how do we balance the need for early broad spectrum antibiotics for sepsis with antimicrobial stewardship? And this is something that's very difficult. This was addressed in the sepsis guidelines and recommendations, and it's something that it's not really agreed upon how to go about doing this. I will stress that antimicrobial stewardship is about using antibiotics correctly. It's not about stopping antibiotics. Some providers get worried when they're contacted for stewardship because they believe stewardship, all they do is say stop antibiotics. But that's really not the goal. The goal is to use them correctly, which oftentimes is, the recommendation is stopping, but using them correctly is really the goal of stewardship. For patients in sepsis, septic shock, or the concern for sepsis or septic shock, really broad antibiotics is something that's recommended, and then you can kind of sort it out later, and that's because it has such a difference in outcomes. So, but it's hard to balance that, and really the antimicrobial stewardship recommendations with sepsis have been to start early broad spectrum treatment, but quickly de-escalate, and that's kind of where it's been. And
then I think that's where procalcitonin comes into play. So when somebody is really septic, they're not doing well, and you start them on 3 different antibiotics, but then do we leave them on 3 different antibiotics for the next 10 days, or can we de-escalate? And when they're doing better, and then procalcitonin is a tool that we could use to kind of help with that.
And so this is a slide showing procalcitonin production. And it's not meant to be too complex. I just wanted to highlight kind of one part down here, and that's with viral infections. Viral infections will stop the production of procalcitonin. And so procalcitonin is being used to discriminate bacterial versus viral infections. And so with viral infections, it really shouldn't cause the procalcitonin to become elevated. There are some other things that we'll talk about later that can cause procalcitonin to become elevated, but viral infections really isn't one of those things. So, and here the rise of procalcitonin is not affected by the presence of steroids. So that's another thing that you know, if your white count goes up, because of steroids, the procalcitonin shouldn't become elevated from steroids. Bacterial infections and cytokines stimulate production. It goes quickly into the bloodstream, and viral infections inhibit the process. So that's the main thing about this slide here.
And it's kind of useful. So like, let's say you're in the emergency department, and you know, a patient is asking for antimicrobials, and you know, if they're worried about pneumonia, this might actually help, like convince, you know, it might help the ER physician say, okay, it's not a bacterial infection, and the procalcitonin is really low. So there have been some studies in that area too, especially in the ER setting.
And this is a comparison of some of the markers here. So the biomarker of fever, leukocytes, cytokines, CRP, procalcitonin. The important thing here is to see that procalcitonin is very specific for infection. So it's the most specific marker we have, or lab value that we have to look for infection. It's not as sensitive, but really its goal is to be the most specific marker. It's rapid induction. We'll talk in a minute about the timeline for peaks in 6 to 12 hours. Correlates with severity of illness. So the higher the procalcitonin, generally the sicker the patient. It's very expensive. Low sensitivity for localized infection. So if someone has a localized abscess, it may not become elevated. And that's something that the patient may have a bacterial infection, but if it's a localized infection, it won't cause the procalcitonin to become elevated. And here is a timeline. So here's procalcitonin. So the important thing looking at this timeline is that when the patient comes in, if they're acutely sick, so if they present to the ER acutely, their procalcitonin may not be elevated early in the course. So the first procalcitonin may be low, but if it's rechecked like the next day or 6 to 8 hours, 10 hours later, it will become elevated at that time. So in that way, I kind of think about this as being like a troponin. So the first troponin may be low or negative, and then if you check it again at a later time, it will become elevated. It takes some time. So there's kind of a lag time there that even though the patient has a bacterial infection, if they present acutely, it may be low.
So it's always important to, if you're going to use procalcitonin, to trend. So, you know, get one on admission, get another one around 12 hours later. And then if a patient is septic, then you could kind of trend it every 48 hours to see where are we. You know, is it coming down, going up?
Yes, exactly. So I think trending it is the most important thing. And sometimes we'll get consulted on a patient and we may get consulted 2 or 3 days in, and they'll say, oh, the procalcitonin was never elevated. And we'll look, and they only had 1 procalcitonin in the ER. And so we'll look at it, and it's not the kind of thing, I mean, we wouldn't order a WBC just once in the ER and then not again during their hospital stay. So it's important to follow the trend and see how that's doing in relation to how the patient is doing.
I really like this graph because it kind of shows you again around 3 hours if you have a bacterial infection, how it's going up, and it's peaking around 12 to 48 hours. But the nice thing is if the patient is on the right treatment, it comes down really nicely, the procalcitonin. But if the patient is not on the right treatment, it's going to stay high, up, or even go higher.
Yes, it'll stay high, or it will continue to become elevated. So if they're not on the right treatment. So I like this graph. Also, I think this is really good. I think here it shows that it may be low. It may be low here when it's first checked in the first couple hours, and then it may become elevated. And it may become elevated the next time it's checked, which may be the next morning. And that it may become elevated and peak even though the patient's on the right antibiotics. So if it's low the first time it's checked, and then the next time it's checked, or excuse me, it's low, the patient's put on the correct antibiotics, the next day it might peak, and then it will start to come down. And even though the patient's on the correct antibiotics, it will still peak the next day before coming down. So sometimes we'll have a question, and the provider seeing the patient will say, you know, the first day or the first night they were admitted it wasn't elevated. The next day it was. Should I change antibiotics? And I usually say, no, that's the procalcitonin peaking. And then if you have them on the correct antibiotics, it will start to come down. Now, if you check it and it peaks, and then you check it the next day and it continues to become elevated, that's when I'd become worried, and I'd say, consider changing antibiotics. We'll move to the next slide. And this is an actual patient. This is a patient, procalcitonin trend for a patient with abdominal sepsis. So you can see that when they first presented, it was low, it peaked, and then started to come down. So this is what we'd expect. So even if the patient were put on the correct antibiotics when they first came in, it would still peak and start to come down. And this is how it should be coming down. It should be coming down about 50% each day that you check with the correct antibiotics. If it doesn't come down, if it goes up, it stays elevated or goes up, that's a poor prognostic factor. The patient has a higher chance of a higher mortality.
Yeah, and I just really like, this is what we end up seeing in a lot of patients, like the procalcitonin starts low and it just goes really high, and then it just goes down as we treat the patient correctly.
And so sometimes what we'll see is that the patient comes in, and here I'll say this as day 1, 2, 3. It could, if you checked it once a day. And so sometimes what happens is that the patient will have it checked in the ER. It'll be low, and then they won't check it again, and they may consult us. They consult infectious disease, let's say on day 4. They'll consult us on day 4, and it will be elevated, and they will be very worried, and they'll say, "Oh my gosh, the procalcitonin is going up," and they will ask us about it, and we'll say, "You know, we're not sure which way it's going. Let's not get too excited if the patient's doing okay. We'll check it the next day, and it will be lower." And so the patients, or the providers, I think the providers sometimes think it's been going along low, and then all of a sudden it spikes up on the 4th day. When really, if they had been checking it, they would see that it actually peaked, and then it's been coming down. So, and that's one way I like to use it, is that when we get consulted, if they only had 1 the first day, we will check it when we get consulted. If that's day 4 or 5, we'll check it, and then check it the next day to see the trend, see where it's going. So I think that's kind of...
trend is very important and very useful.
Let's see. So here, this is the procalcitonin levels correlate with severity of illness. So generally, the sicker the patient, the higher the procalcitonin. And so you can see the no SIRS, no infection, SIRS, no infection, sepsis, severe sepsis, septic shock, it just goes up and up. And this is generally something we see. So the levels for the studies where they choose what levels to start or stop antibiotics are kind of, they just kind of choose those arbitrarily. So I try not to get caught up in the exact number of it, especially if it's very low. It's more so checking it the next day and seeing if it's shooting up or coming down.
It's a trend,
Yeah, so I try not to get caught up in it's you know, slightly above or slightly below the number where they're recommending starting or stopping antibiotics.
And sometimes, like in the when a patient is really sick, for example, if they have a gram-negative bacteremia and they're really in septic shock, the numbers can be really high, can go up to like 140. And then when you have them on the right therapy, it'll go down to normal range. Oh, somebody has pneumonia and a bacterial pneumonia, the numbers can be just 1 or 2. So like Dr. Horn said, like it's not how high the number is, it's the trend that's important.
And this is a slide showing, there was a study showing that procalcitonin levels can be prognostic. So this was looking at procalcitonin in ventilator-associated pneumonia survivors and non-survivors. So the black is the procalcitonin on day 0, and the red is the procalcitonin on day 4. And you can see the survivors here on the left had lower procalcitonins, and the non-survivors had it rising at higher numbers. So mortality associated with the peak, the procalcitonin peak is associated with mortality. Increasing procalcitonin, so if it's going up, if the procal continues to go up, even though you're giving antibiotics, it means that it's a poor prognosis. I would consider changing antibiotics. Even if you know, there are very few times where even we know we have the right antibiotics and it continues to go up. It's very poor prognosis. Those patients don't do well. The initial procalcitonin is not predictive. So the timeline that we looked at just a few slides ago, where it was initially low, that's just showing that it hasn't risen yet. It hasn't had the time to be produced and become elevated. So this is highlighting some of the important information. Procalcitonin increases within hours of bacterial infection. It decreases daily by about 50%, and this is 50% each day if the patient responds to therapy and the infection is well controlled.
I really like this slide because you could see bacteremia with response to treatment really elevated procalcitonin, and it comes down really nicely. But the next graph, it shows bacteremia without response to treatment. The procalcitonin continues to go up and stay high. So, get the patient on the right treatment, we're going to get the procalcitonin down. Again, pretty similar on the bottom graphs too. Severe sepsis, response to treatment, and not response to treatment. So if it responds to treatment, your procalcitonin is going to come down. But if it's not going to respond, it's going to stay high. So the key is it's really good tool to kind of trend and see how the patient is doing and if your treatment is working. And not a diagnostic tool, but like Dr. Horn said, a prognostic tool to see how they do.
And this was a study in Lancet in 2010. This is a very important study for procalcitonin. This was a multi-center randomized open label study. They were looking at the safety and effectiveness of procalcitonin. They looked at endpoints with mortality and antibiotic use. So this slide kind of has a lot, but it's the main thing they looked at was mortality and antibiotic use. They excluded children, bone marrow transplant, neutropenia. Procalcitonin can still be used in that population, but it wasn't used in this study.
And I really like this graph because basically this graph, it's a Kaplan-Meier graph that shows that there was no difference in survival. So that means that procalcitonin didn't improve survival, but it didn't affect survival either. So both groups ended up being the same. But what's important is the next graph where procalcitonin use did help decrease antibiotic that was used, antibiotics days. So survival was the same, but it helped, providers decrease antibiotic use, which is always very good. And, right antibiotic for the right duration was kind of illustrated here.
Yes, and as we said in the beginning, that decreasing antibiotic use is very important to decrease resistance, C. diff. Antibiotics are one of the few things that if you give it inappropriately to one patient, you're negatively affecting the rest of the patients and essentially the rest of society. So decreasing antibiotic use is the use of procalcitonin and a very good way to use it. One thing about this study was that the providers that did use procalcitonin, many of them didn't use it as they were supposed to and didn't follow it very strictly, but they did order it. And so just by ordering it, they were able to decrease their antibiotic use. And that was something that was seen in other studies, was that when they're able to see the results of procalcitonin, it changed how they approach the patient. Now, I wanted to include this because this is something that I wanted to just highlight that different studies use different cutoff values, and some hospitals will use this, and a result like this will come with the result. So when a procalcitonin is ordered, they may have an interpretation of it saying, if it's low, you strongly discourage antibiotic use, you discourage antibiotic use, encourage or strongly encourage antibiotic use. And this is for lower respiratory tract infection. So they use the charts like this for pneumonia, and then the next slide, they use it for sepsis. Generally, procalcitonins should be used to stop antibiotics and not to start antibiotics. So if you have 2 procalcitonins that are low, that would support your decision. If you're already thinking about stopping antibiotics for the patient, 2 low procalcitonins would support your decision to stop antibiotics. So that's kind of the way it has been studied and should be used. Is if you have 2 low procalcitonins, about 8 hours apart or so, and they're both low, then the likelihood of a bacterial infection is low, and you're already thinking to stop antibiotics, it supports your decision.
And this was a really big study that just came out too in 2017. They looked at large trials, about 26 trials over 12 different countries, more than 6,000 patients. And what they saw was if providers use procalcitonin guided therapy, there was actually significant lower mortality. And also added benefit was lower days of antibiotics, about 2.4 days.
So, and this study and this is a very good study because it's so large and so recent. And this showed a mortality benefit which wasn't seen in the previous study. And that's fewer days of antibiotics and lower mortality. In this study, they also didn't all use procalcitonin as it's supposed to be used. But I mean, just ordering it, they had such a big
and also they used it in across so many different settings, like in primary care setting, emergency department, ICU, respiratory infection. So they used it across different settings and, had significant outcomes.
So false negatives.
Yeah, false negatives. Like me and Dr. Horn, we always get these questions. So the graph that Dr. Horn showed earlier, it showed how you have cytokine production that leads to procalcitonin being released in your body. But when you have a localized infection like an abscess or infection in your pleural space, empyema or mediastinal area, what happens is you don't have that whole body reaction to release those cytokines to make the procalcitonin go up. So sometimes, if you think a patient has infection and they have an abscess or this type of infection, they still do. So procalcitonin in those cases might not be helpful. It's false negative. And again, if you draw it too early and you don't trend it, you might think it's not high, but it's going to become high, just like that abdominal sepsis patient we showed earlier. So drawing it too early and localized infections, you might get a false negative results.
And really, you should always go with your clinical suspicion.
Mm-hmm.
So if you think this patient has an infection, then you should not withhold antibiotics because the procalcitonin is low. You should say, my clinical suspicion is that this patient has an infection. so I'm going to give antibiotics. And that was actually a question at the Infectious Disease Society of America. They had one of their national meetings. They polled the audience with infectious disease providers, and they asked them, so if you are seeing a patient and they had 2 procalcitonins that were low, but you clinically suspect that they have an infection, would you stop antibiotics because the 2 procalcitonins are low? And they polled the audience, and they essentially all said, no, we would, if our clinical suspicion is that the patient has an infection, then I would continue antibiotics and go with my clinical suspicion. That was what the response was when the infectious disease providers were answering with their clickers. And I completely agree with that. Yeah. I think you should always go with your clinical suspicion over the procalcitonin. And this kind of highlights the point that you shouldn't use procalcitonin to start antibiotics. So you should use it to start, and then later, if you're considering stopping, you can use it to stop antibiotics, but not to start.
And then there are some false positive areas where you could have elevated procalcitonin, but the patient doesn't have an infection, like trauma, shock, surgery, burn, inhalation injury, pancreatitis, treatment with agents that stimulate cytokines. So what all these things have in common is that it's going to create an inflammatory response throughout the whole body. And when that happens, your cytokines are going to get stimulated, and that's going to lead to release of procalcitonin. So this can cause false positive procalcitonin, or something to keep in mind. But do trauma patients get infection? Yes. So the next slide will kind of help with that. So, just let's say a patient with trauma comes in and their initial procalcitonin is 2, but you're treating them, you're still suspecting maybe an infection, but you're starting to trend the procalcitonin in the trauma patient, and it continues to be high or go up, then you're like, maybe they have trauma plus an infection. So, trend in those patients is more helpful, but they might have a higher starting point with procalcitonin.
Yeah, I completely agree. So I don't feel like I see false positives very frequently. Mm-hmm. I think if the procal is high, I would still suspect an infection. I sometimes want to see the trend before I say it's a false positive. I think that's very important. And as far as there are some types of cancers that can cause procalcitonin to become elevated, and dialysis can also cause it to be elevated. But if it's high, it should be consistently about the same number. If it's shooting up, I wouldn't say it's due to dialysis or cancer or anything like that.
And the only one big cancer that causes really high elevated procalcitonin is thyroid cancer, because procalcitonin is produced in majority of the time in your thyroid glands. So that's something to think about.
So in the real world, it may not be cost effective. So procalcitonin is something that's expensive. And hospitals kind of have to deal with the question and look at the kind of debate within their hospital. Is procalcitonin something that they want to offer? And I mean, it may not be cost effective, but as you see, it did have it did decrease mortality, and it did decrease antibiotic use, and decreasing antibiotic use can have multiple effects on a hospital and the area that are kind of hard to quantitate and show dollar savings for proper antibiotic use. I think in the future there will probably be a lot more studies showing that it does help.
Like some of the hospitals we have worked in, the procalcitonin, if you draw, I think it's about like $100 per every time you draw it. But if you actually think about, like, that's expensive, but let's think about the patient's mortality and the amount of antibiotics and the risk of C. diff. I think that all plays into, it might actually be really worth it to use that.
And then procalcitonin might not be used as it was in studies. So I kind of think of it like a D-dimer. So a D-dimer, they get used frequently, but they're not always at the points where they should be used, or they were at points where they were studied. So procalcitonins, sometimes I'll see it be used, but it's not always used in a way that would be supported by the evidence, by the studies that were done. And so and this actually is another question where some hospitals will ask us, they'll say, should we have procalcitonin on our sepsis protocol? And that, I think, should really be looked at each hospital individually. I really like procalcitonins. I like using them. We order them frequently on our inpatient infectious disease service. But I wouldn't say it should be mandatory for other providers to use them in situations because the providers may not be as familiar with procalcitonin, and if they get a result back, they may not interpret it correctly.
Yeah.
So if they have a sepsis patient and then they check a procalcitonin and it's low, they may not interpret it correctly, and they may not know that you need to check another one at a later time. And so I wouldn't want them withholding antibiotics or not using the test as it was intended.
Because sometimes people think it's a diagnostic tool for infection, and that's what we want to emphasize. It's not a diagnostic tool, it's a prognostic tool. So it's a trend, and are we treating the infection correctly, and reduce the antibiotic use. But just because it's low, like you were saying, just like that example we gave earlier, abdominal sepsis, if we withheld that antibiotic for that patient could have had really bad outcome, because the next day it shot up to like 1 to 81. So it's not a diagnostic tool. And I think more and more we talk about this and more education, I think providers will get more and more comfortable.
And then the last one, clinicians may try to use it to replace clinical judgment. And really they should, and that's part of why we're doing this webinar, is to look at what causes it to be elevated, what causes it not to become elevated, and to try and make a good clinical decision. And really, one other question we get is ordering. We'll have people say, "Why are you ordering a procalcitonin if that's not going to, if you're not going to make your decision based off of the procalcitonin?" But I look at that kind of as I wouldn't base a clinical decision solely off of the leukocytosis or solely off of one value for the patient. I try to get as much information as I can and try to look at it as a whole. So I wouldn't check a procalcitonin and base my whole decision off of that, just the same way I wouldn't base it off of another, just one lab value. Yeah. So procalcitonin is the most specific biomarker for infection, and it has advantages over previous markers. It isn't perfect. The trend is the most important thing when you're thinking about procalcitonin. A low level cannot rule out infections. Be aware of conditions which may affect procalcitonin levels, like localized infections. We can't be replaced by robots yet, maybe someday, but good clinical judgment should always be applied, and we'd recommend always going with your clinical judgment, not basing your decision solely off of the procalcitonin. And don't treat or not treat a number. So I wouldn't just order procalcitonin and say, this is my reason for treating or not treating.
We could open up to questions now if you guys want to unmute and ask us for questions, or you could type in.
And if anyone has any questions, feel free to ask any questions.
Yeah.
I would like to also say that one way that it was used in those studies is if the procalcitonin decreases from a peak, about 80 or 90% of its highest point, then you can stop antibiotics at that point. And so that's the way to use procalcitonin, to shorten the course of antibiotics, to say, once it's come down about 80% of its peak, you should feel comfortable stopping antibiotics. And usually with durations of antibiotics, the durations sometimes they're not always the best studied. And with more and more studies coming out, they shorten the course to just a few days sometimes. They may in the past, they used to say something like 2 weeks, or then they go to 10 days, then they go to 5 days.
Now it's 7, 3.
Yeah.
So like, especially with like pneumonia, let's say a provider was planning to treat this patient for 10 to 14 days, but at day 7, the procalcitonin is back to normal. like that tells you there's no need to continue any more antibiotic. Like it's back, you know, it peaked at 10 on day 2. At day 7, the procalcitonin is 0.3. It's like completely in the normal range. So if your plan was to treat that patient for like 10 to 14 days, you could comfortably stop at like 7 to 8 days and you know, eliminate the rest of the antibiotic use.
Yeah, and that's how we use it, is to stop antibiotics. And another question we'll frequently get is, do you check a procalcitonin every day?
Mm-hmm.
So do you usually
For
check
me, when I see like septic patients, I like to, what I usually do is like if they're really sick, hypotension, pressors, I like to do admission 12 hours later, and I trend them every 48 hours. Pneumonia patients, if they're stable, you know, on admission 12 hours later, maybe every other day too, but that's kind of what I do every 48 hours to kind of see the trend. You get it every day too, but I just, you know, if I see a trend going down, then I just do it every 48 hours.
Yeah, and that's, I mean, infectious disease service will order it more frequently than I think other providers do, but I completely agree. I think I don't order it every day on every patient. I kind of look at the patients and I'll say it may be useful to stop antibiotics in this patient, or if you have an extremely sick patient, you know, I'm wondering where it is, and we can look at it in relation to everything else.
Sometimes if I ordered one yesterday and somebody was really hypotensive, it was like 50, and then the next day they don't look too good, and I order it, it's at 100, and I'm like, oh, I'm doing something wrong because it's going up. I have them on triple therapy. Maybe they have a resistant organism, so I need to kind of change my antibiotics. So it kind of helps me that way too. So it's kind of like case by case sometimes too.
Yeah, and when we first started ordering it, we'd see patients that clinically, like, they were looking okay, but the procalcitonin started going up and was starting to elevate. And I would look at them and I'd say, this patient actually looks okay, but the procalcitonin is going up, saying I'm on the wrong antibiotics. And when I first started doing it, I didn't believe it. and then a couple days later, the patient may crash, or they'll, all of a sudden they're doing worse. And I'll say, but I don't do that anymore. Now, if the procalcitonin starts going up, I'll change antibiotics. I won't wait for the patient to do poorly.
Because for me, it's saying that I'm not giving them the right therapy. Well, is there any question, guys? Any good type or unmute and ask us?
And one last thing, I'll say that with stewardship, sometimes we'll review a case with a pharmacist, and they'll say this patient's on antibiotics. It looks like they can stop. And we'll say, well, have they ever had a procalcitonin? And they'll say, when they first got admitted, they had one that was negative, that was negative. And we'll say, well, perhaps you should ask the provider if they think the patient has an infection. And if they say that they don't think they have an infection, you can check a procalcitonin now. And if it's still negative, then that would support your decision to stop antibiotics.
Wow.
All right, well, not having any questions. I hope all of your questions were answered during the talk. Thank you very much, everybody, for joining us.
And then we'll see you guys next month for a different topic.
Yes, we're happy to. Please email us any questions that you have, and please email any topics that you'd like us to discuss in the future.
Yeah, if you want to let us know what topics that will be, you guys will find helpful, then we could prepare that for the future talks. Thank you.
All right, thank you, everybody. Have a good day.